This podcast is sponsored by the American Academy of Orthokeratology and Myopia Control. My name is Dr. Tom Wachowski, and I will be your host for this ongoing podcast series. By continuing to interview the world's leading authorities in orthokeratology and myopia control, I hope to keep you up to date on the latest news, research, and information, and to give you the tools that you can use to better serve your patients and to help grow your practice. Joining me on this episode of the podcast, it is my absolute pleasure to welcome Dr. Mike Lipson. For those of you who may not know, Mike is an optometrist and assistant professor in the Department of Ophthalmology and Visual Science at the University of Michigan's Kellogg Eye Center. His clinical practice involves contact lenses with an emphasis on specialty contacts for overnight corneal reshaping, keratoconus, post-corneal transplant, post-refractive surgery, and severe dry eye patients. He's actively involved in clinical research as the principal investigator for studies on corneal reshaping, vision-related qualities of life, myopia control, and new lens designs. He's been published in many peer-reviewed journals. He lectures nationally and internationally on specialty contact lenses and research topics. He's a fellow of the American Academy of Optometry, as well as a fellow of the Scleral Lens Education Society. And in his spare time, he serves as the vice president of the Scleral Lens Education Society. And he's just an all-around nice guy and a good friend. And so with that, Mike, welcome to the podcast.
Well, thanks for having me. It's kind of a new technology. It should be a fun night today.
Okay, yeah, I'm looking forward to it. You know, people don't know, but you and I have been trying to put this together for a very, very long time. And mostly it's on my part that we sort of put it off because I've taken a hiatus from doing podcasting for the past 8 or 9 months. There's some big projects I have going on outside of the academy, and I actually might make them a topic for a future podcast. We'll see. I'm going to take that under advisement.
Okay.
So, you know, one of the big topics that was floating around on the Google group just maybe about a month or so ago when you and I decided to put this together was the topic of, you know, at what level of myopia would we really begin to start thinking about Ortho-K as the primary means of myopia control? You know, typically for low myopes, we'd think soft multifocals or possibly atropine, but the topic really came up about what level, how myopic does a child have to be in order for myopia control to be effective by using Ortho-K. So okay. I kind of wanted your take on that.
Well, very good. It's a wide open subject right now, and really there is not a preponderance of research now to support any theory whatsoever. But I guess, first of all, I wanted to say I don't think that there is any level of myopia that we should not consider Ortho-K for these kids. And I would say, you know, at the bottom of the barrel, maybe -1, okay? Now, obviously, in the discussion that you're talking about, there were a number of people who supposed that they showed that even with Ortho-K and myopia-controlled design lenses, that kids still progressed faster if they were low in their myopia. And really, there is no definite study to support that. Now, there's a lot of conjecture and a lot of things that kind of mix up all the data that we see. I guess, first of all, one of the things that shows up almost uniformly throughout all studies of myopia progression, whether it be in kids that are wearing Ortho-K, kids that are wearing glasses, or no correction whatsoever, is that younger kids tend to progress faster in their myopia than older kids. And you've seen those studies, yes?
Absolutely. And that's also my clinical experience.
And so what we are conjecturing about is we've seen some of these kids who we put in Ortho-K who are very low in their myopia, and they still seem to progress more than, say, these, say we take a minus 150 myope and we put them in Ortho-K, and a year later, we have to bump up the prescription a little bit higher, the treatment effect a little bit more, because, they're undercorrected. So we think, okay, they progressed. Well, again, maybe it's slower than they would have been otherwise, but again, that same kind of patient that we might approach who was -3 seems to have more control. They don't progress as much. Now, relative to any studies that were done on this, a lot of the myopia control studies with Ortho-K are done on kids just a little older. Average age is usually about 10 or 11, usually in most of these studies. The ultimate goal is to say, have we stopped growth or increases in axial length? Okay?
Yep.
And most of those show that Ortho-K definitely does not only slow refractive increases or manifest refractions, but axial length changes too. Usually it's somewhere in the 40 to 60% range. And one of the studies that looked at one was a 5-year study from Japan, and it was about 47%. The classic study that is always looked on as one of the best studies on myopia control with Ortho-K is done by Pauline Cho, and there was a randomly controlled trial. Most of these studies are not RCTs. And that showed about 43%. And one of the things that I guess I found most fascinating with hers is in that study, she actually broke down the myopia progression in terms of kids in her study that she described as fast progressors versus those who were slow progressors. In her study, they were age 7 through 11. And so the 7 to 8-year-old kids she subcategorized versus the 9 to 10-year-old kids. And in the younger group, kids that were wearing spectacles, these are the control kids, 65% of them fell into the category that she called fast progressors. In the same younger group, the kids that were in Ortho-K, there were only 20% of them who were considered fast progressors. Now, in her study, the mean refraction that started off was about -250, so it was not low, not a high one. But again, in these older kids, the fast progressors, there were 13% fast progressors in the spectacle wearing group and only 9% in the Ortho-K. So in other words, in both groups, in the control group and the Ortho-K group, the younger kids progressed faster. There were more of them like that.
Right.
So again, the question that I always ask in this, is it age, and these are the kids that are the low myopes, or is it, the amount of myopia? And we don't really have a definitive answer for that.
One of the things that, when I look at all these studies, and you just mentioned several good ones, and they're talking about percentages that clinically, I would say that most experienced Ortho-K fitters would find those percentages to be very low. That, the 40 to 60% range of myopia control. And I can tell you that I believe my numbers are much higher than that. And, my theory behind that, and I asked this of Earl Smith a few years back, and I actually even at Vision by Design did a presentation on how to design the ideal myopia control lens, if there really is such a thing. And it really, I think, pertains to, if we assume now that the peripheral defocus theory is really what's at play here and what's really slowing down this myopia. But if we look at that, I think you really need to have a study that controls for pupil size versus optic zone size. And I don't think anyone has ever done that. I believe that Jaume Pane in Spain is working on something along those lines now. Mm-hmm. And I'm not aware of him publishing anything yet. Are you familiar with that?
Oh, yeah. And really, any of these myopia control studies, whether they be Ortho-K, time outdoors, atropine, there's always so many confounding factors that you can't seem to control every single facet of this.
Right.
And that's the frustrating part of this. And, you know, we kind of take a few studies and take some information, and as you suggest, you know, there may be factors such as pupil size, maybe treatment zone size, how much of a treatment zone we create, how much myopic defocus we create, and at what point on the retina we create it, if you're taking just that theory. But interestingly enough, you kind of led into the next thing that I was going to talk about with this, but we did a retrospective study. This just was recently published. It took a long time to get this published, but it was just a retrospective study with no control group. And just like you, the reason I did this study was that, well, I felt like I was getting 100% myopia control.
Right.
I had these kids that were coming in for years and years wearing the same lenses for 6-7 years. No changes necessary. And like I said, from a clinical standpoint, we get the feeling we're doing wonderful.
Right.
And because we watch these kids, we don't really take them out of lenses because they don't want to stop wearing lenses, so we don't really refract them. But I started doing axial length measurements on kids back in 2007 as part of the SMART study.
Right, and you were way ahead of the curve on that.
And so basically after, while we were doing that SMART study and shortly after it ended, we had started doing axial length on everybody, not just those kids. So basically I had a number of patients who I had axial length measurements on, and I had baseline axial length measurements before they started, and this was a 3-year study. And now, like I said, the problem with getting this study published is all the reviewers wanted to see a control group, okay? And we didn't have a control group. It was just a large case series. We ended up with 97 kids that we followed like this, 194 eyes. We did both eyes. Some of the studies will not do both eyes because of other confounding factors, but they were treated independently. In 3 years, for all of these kids, the mean axial length change was 0.28 millimeters. So like I said, we don't have a control group. We can't say, okay, it slowed myopia progression by so much %. But one thing I can tell you, kind of relating back to Pauline Cho's study, is that if we looked at those numbers a little differently and looked at these kids, we had 65% of them who had little or no change in axial length. So that's looking at it slightly different than those other percentages. But that's a lot of kids that had very little change. And when we did this and broke it down by age, like we were just talking about, in 3 years, the kids that were in the 6 to 7 year old range, we had a few of those, not a ton, but we had enough, was 0.57 millimeters, okay? At 8 to 9, 0.46, 10 to 11, 0.15, and the kids that had started Ortho-K at 12 or over, essentially no change in axial length in 3-year time span.
So it is really age dependent then, is what you're telling me.
That's what I sensed in our findings. Bearing on what you just mentioned, we did have baseline readings on these kids for pupil size, corneal diameter, baseline K readings, their starting RX, and their age at the start of this. And through all my statisticians and the help that I got from all those people, essentially none of those other factors played any part other than age at start.
Really?
It's kind of cool.
Yeah.
So I thought there was going to be a difference in pupil size, and we took average room illumination pupil size. The best we could do when we published that study was to get a study that was published in Spectacle Wearers in 2005 in terms of trying to find what is a normal change for axial length in kids who were wearing glasses. And there was a study done by Hyman where we had in the 6 to 7 year old wearers 0.57 millimeters of axial length change in 3 years. Spectacle wearers in that group about double, 1.1. Where we had in this 8 to 9 year old range 0.46 millimeters increase, this 8 to 9 year old spectacle group 0.82, about double. And this is just axial length. And then it actually 10 to 11 where we had 0.15 millimeter change. These guys in the spectacle group 0.57, which is about 4 times as much in that age range. So again, just like you as a clinician, and most of the people who are going to listen to this are interested in Ortho-K, it works.
Absolutely.
It slows myopia progression. Again, we haven't come up with the ultimate answer as why it works, if it is just the peripheral defocus, if there's other factors involved. But we're doing something good. As clinicians, we know we're doing something.
Now, if you were to look at the patients that you're treating, your young myopes,
yep,
Ortho-K would be your primary means of myopia control?
That is definitely my first choice. You know there's other methods. We've been discussing it at the meetings and such. But I think the biggest advantage of Ortho-K is, number one, compliance. The kids like doing it, so they do it.
Sure.
And if I could compare that to the kids that we've done on atropine who weren't either ready for lens wear, I don't get the feeling they comply as well.
Right. Well, you know, it was kind of interesting in my conversations with Tom Aller. He said, given a choice, that, and he is definitely a proponent of soft multifocals, but he said that given a choice, the patients 85% of the time will choose Ortho-K just because of the associated benefits of no lens wear during the day.
Yep.
And again, I would say that bears out in my clinical practice. I don't do a lot of soft multifocals. I do some. I do usually gravitate towards Ortho-K. And I do have some patients on atropine, and there's a lot of interesting information coming out about atropine now, and that recently published World Health Organization piece that came out about a week or two ago, and they are touting the benefits of atropine. Yet from what I'm hearing from some of the recent studies in Taiwan and China, that perhaps low-dose atropine, at least in Asian children, is not really producing the results that they were expecting to find.
Right. And they've been using atropine for a long time.
Right.
They've been doing it a lot longer than we've been talking about it and doing it. And they had a lot of myopia, and they had very compliant patients with atropine, I think. And they just said, here's what you're going to do, and they did it. We have a difficult time here keeping that same level of compliance, I think. Our kids aren't going to stand for some of the things that they have to do.
Right.
So, as you kind of alluded to, I guess when I was preparing for some of this thing, I looked up and I found one quote from a former Surgeon General, Everett Koop. Remember him?
I do remember that, and I think I know the quote you're going to use, but go ahead.
It says, drugs don't work in patients that don't take them. So, atropine, as much as it's effective, if the kids aren't going to do it, it's not going to work, number one. Number two, I don't know, I think the fact that in Ortho-K, the effect is always in play, as long as they're awake.
Right.
And as much as I would like to think soft lenses are going to do great for this too, they can't wear their lenses 24 hours a day. And they can't wear their lenses all their waking hours even.
Right.
So they're going to go back to their glasses for some time and maybe lose some of that benefit. So that's why I lean toward Ortho-K. When the kids are compliant, they do it, as you know from your own personal experience. Kids
Sure.
love it. And they don't want to give up those lenses no matter what. And they're sometimes afraid to tell you if their lenses are bothering them because they think you're going to tell them to stop wearing them for a couple days.
Yeah, it was kind of interesting when my oldest first went away to college, knowing what college life is like and realizing that, he'll be up late, he'll be out late, he may not be coming home, that perhaps in a social setting, Ortho-K could be a bit of a hindrance in that, it's not always socially convenient to be saying, well, excuse me, I have to put my retainers in. Mm-hmm. And so before he went off to school, I offered to put him into soft lenses, and I was sort of surprised. Maybe I shouldn't have been, but he absolutely refused. He thought it was the most ridiculous thing he had ever heard. Like, Dad, why would I do that? I mean, I love my lenses. I see great. I don't have any problems. Why would I do that? And I tried to explain to him, I don't think you really understand what college life is like, and that you'll be up late. You may not be getting enough sleep. He absolutely refused, and he did just fine all through college, which really kind of surprised me. And his younger brother, my youngest, is now a sophomore at Georgia Tech, and he did the same thing. He wouldn't want to do it any other way.
It's funny you say that, too, because I get a number of kids who've been wearing lenses for many years. They start when they're 8 or 9 years old. 10 years later, they're going off to college, and the parents or the kids ask me, well, how long should I wear these Ortho-K lenses? And a lot of them have the impression that it's just for kids.
Right.
And I usually present it that, just like you said, wearing time seems to be the only limiting factor. And I tell them straight out, obviously if you do stop wearing these lenses, you're going to have 3 choices. 1 is to wear glasses during the day. 2, to wear contact lenses during the day, or when you get old enough, have LASIK. Now, when faced with those 3 options versus remaining with Ortho-K, I would say the ones that have done very well with it and enjoyed it, it's no decision at all.
Right.
They want to stay with Ortho-K.
Right.
I guess in that kind of a discussion, maybe we should go the other direction and say, what's the youngest age? We should talk about Ortho-K for kids.
Well, I can tell you what the youngest I've ever done, and it was both my sons, and both of them at age 6. Now, it was a little easier for me because I'm not going to be squeamish about putting a lens in their eye. Mm-hmm. And, obviously they had me to take care of them. My younger son was really kind of interesting. Actually, they both were. The oldest, I thought I was going to be putting them in and taking them out for him. At age 6, I didn't really even teach him for the first, I wasn't planning on teaching him for the first couple of weeks. So the first night he wore them, I put them in. He woke up in the morning, I removed them. He was fine. His vision was good. The next night, I said, okay, let's go put your lenses in. And he said, no, I'll do it myself, Dad. I said, well, no, you can't. He's 6 years old. And I said, Daddy will do it for you. And he locked himself in the bathroom. And he said, no, I'll do it myself. And I at first started, banging on the door, open this door now. And then I realized, just leave him alone. Let him do it.
He was motivated.
He was highly motivated. It took him 20 minutes, but he got him in. And in the morning, he got up and he removed them himself. And I didn't really even train him. I sort of showed him, but I didn't really sit and do a training class with him. And I've never had to touch his lenses after that first night of wear. My younger son, he was a bit different, and I had to do his for years because he never wanted to. He knew how. I taught him how, but he just would rather that I do it. And it was kind of interesting. We had to bribe him with that new big Lego set. And his first night, I put them in, and he was fine. I was really kind of surprised. I thought he was going to fight me. I tucked him in, turned out the lights, left the room. About 10 minutes later, he starts crying, Dad, get him out, get him out. I don't want lenses. I don't want lenses. And I just went in and said, buddy, you're fine. Just go to sleep and you'll be fine. Well, what I didn't realize was that after I'd put him in initially, he was rubbing his left eye and he dislocated the lens and it was off on the sclera. So it was really uncomfortable. When he woke up in the morning and he came into the bedroom and asked me to take him out, that's when I discovered what had happened. But it was very interesting because with his right eye that he hadn't rubbed, his vision was good that day. And he realized that, wow, wait a minute, I rubbed my left eye and it hurt, and now I can't see. I thought he was going to fight me that night, but I've never had an issue with him. And he, again, to this day, just like his older brother, I've never had to redesign lenses for either one of them. And for me, that was pretty cool. So 17 years ago, we had no studies that were going to say that this was going to be effective in controlling myopia, but there were just an awful lot of clinical, or I should say anecdotal reports, and I was seeing it in some of my own patients and hearing it from the few other docs that I knew that were doing Ortho-K, that it was working, and I thought, well, I have two choices. I can put them in glasses or soft lenses and just watch them get worse, or I can try this Ortho-K and maybe it'll slow them down. And so I was obviously very happy, and that really made me, pushed me to want to learn more about Ortho-K and delve further into it.
Well, those are great stories, and we get those from our patients, and I guess the most gratifying ones are the kids that, like you said, that may not be too excited about it at first. They're not quite sure about it, and they wear them that first night, and they say, oh, I guess that's okay, I can sleep in them, and I woke up and my eyes are feeling much better now that I've taken them out, and boy, I can really see.
Yeah, that's pretty cool.
And so usually after that first night, they're kind of hooked, and they love it. So that's why I said, if possible, if the kids are motivated, if the parents are supportive, Ortho-K would be my first choice for these kids, both for lifestyle and quality of life issues as well as myopia.
Stay tuned for part 2 of my interview with Mike Lipson, where Mike and I discuss the FDA workshop on myopia control, Ortho-K for adults, Ortho-K on post-LASIK patients, and what he hopes we might see in the future for Ortho-K. But more about that next time. To join the discussion about this episode, log into the Ortho-K podcast forum located on the American Academy of Orthokeratology and Myopia Control's web portal. This is Dr. Tom Wachowski. Until next time, thank you very much for listening.